Let me ask you this. What if one bad fall in your 70s didn't just break a bone, but stole your independence forever? And the shocking part? That's not a rare scenario. Millions of older adults face it every single year.
Most people think fractures just come with age, like it's some unavoidable curse of getting older.
But that's the myth. The real story is far more complicated and much more preventable.
Because hidden forces, things like inflammation, medications, and nutrient imbalances, are quietly weakening bones long before the first crack ever shows up.
A bone fracture in your 70s or 80s isn't just painful, it can take away independence permanently. About 1 in 3 women and 1 in 5 men over 50 will suffer an osteoporosis-related fracture in their lifetime, showing just how common this risk really is. The surprising truth is that many fractures are fueled by hidden causes, not just age. Medications, ongoing inflammation, and nutrient imbalances all play a role in weakening bones. Calcium supplements, especially large single doses, have even been linked in some studies to risks outside the bone, while dietary calcium behaves quite differently. In today's video, we'll break down myths, uncover these overlooked threats, and give you practical steps to protect your bones. And as you'll see next, the belief that fractures are simply part of aging may be the most misleading myth of all. The idea that bones inevitably weaken as the years pass is one of the most enduring misconceptions about aging. This belief, that bone loss is hardwired into the body's clock, causes many people to accept fragility as unavoidable. But the truth is that age alone does not dictate fracture risk. What matters more are the underlying processes, from inflammation and hormone changes to nutrition, physical activity, and medical conditions. By recognizing these factors, it becomes clear that fractures are often preventable. The statistics, often cited, 1 in 3 women and 1 in 5 men over 50 experiencing osteoporosis-related fractures, are sobering, but numbers without context can be misleading. These figures show how common fractures are, yet they do not prove inevitability. In fact, research shows that interventions, from targeted lifestyle changes to bone-sparing medications, can produce measurable benefits in as little as 12 to 24 months, even for those already diagnosed with osteoporosis. This means that bone decline is neither irreversible nor unavoidable, and opportunities for improvement exist well into later life. A major driver of bone weakness is something scientists describe as inflammaging. Instead of inflammation in response to injury, this is a low-grade chronic process that becomes more active with age. It speeds up bone resorption while slowing bone formation, gradually tilting the balance against skeletal strength. This is why bone loss depends not only on how old someone is, but on what is happening inside their body. The good news is that inflammation can be influenced through diet, exercise, and treatment of chronic conditions, making it one of the key areas to address for preserving bone health. Screening also plays a crucial role in prevention. Guidelines recommend that women begin routine fracture risk assessment at age 65, while men are advised to start at 75. These evaluations help identify those at greatest risk early, which is critical because a first fracture dramatically raises the risk of future ones. By acting at the right time, the window for prevention and treatment remains open, even in later decades of life. One way to picture how bones change across a lifetime is to think of them as a kind of bank account. Healthy choices add deposits, weight-bearing exercise, protein-rich diets, and adequate vitamin D and K intake. On the other side, withdrawals come in the form of smoking, prolonged sitting, nutrient gaps, chronic disease, and certain medications. Over time, strength depends less on the age of the account and more on the balance of deposits and withdrawals. This perspective helps to explain why 2 people of the same age can have very different bone health outcomes. Understanding this balance also sheds light on why isolated calcium supplementation doesn't solve the problem by itself. If chronic inflammation, inactivity, or medication side effects are steadily making withdrawals, simply adding more calcium will not restore the account's overall health. Protecting bones requires identifying and reducing the drains while continuing to invest in what strengthens them. The larger lesson here is that weak bones are not a simple consequence of aging. They result from a web of interactions between biology, lifestyle, and medical choices, many of which can be influenced. That influence begins with building awareness, getting tested at the right time, and asking the right questions about what might be accelerating bone loss behind the scenes. And that brings us to a factor most people overlook. Some of the very treatments prescribed to help with other conditions can act like hidden withdrawals on that bone account, gradually weakening the skeleton without obvious warning. It may surprise you just how many medications fall into that category. Some of the most underestimated threats to bone strength come not from aging itself, but from the very medications people rely on to manage chronic conditions. This silent sabotage of medications often goes unnoticed because the drugs are prescribed for valid reasons, and their effects on bone health are seldom explained clearly during routine care. But research now shows that several widely used drug classes carry measurable risks for fractures, especially when taken long-term. One example is proton pump inhibitors, or PPIs, often prescribed for acid reflux and heartburn. While they relieve discomfort and protect the stomach lining, long-term use, generally more than a year, has been tied to a modest but consistent rise in hip and vertebral fracture risk. The suspected reason is that PPIs reduce calcium absorption in the gut, leaving less of the mineral available to maintain strong bones. If you've been on a PPI for years, it's worth asking your doctor whether the benefits still outweigh the risks and if your bone health should be evaluated alongside digestive care. Antidepressants are another category with hidden effects. Selective serotonin reuptake inhibitors, or SSRIs, are commonly prescribed for depression and anxiety, but studies show that those using them have about a 1.7 times higher risk of fractures compared with non-users. The link does not always show up in bone density scans, which suggests that SSRIs may disrupt bone repair and balance in other ways. If you use SSRIs, especially alongside other risk factors like age or prior fractures, raising the question of bone protection with your clinician is an important step. Steroids, also known as glucocorticoids, bring relief from painful inflammation in conditions such as arthritis and asthma. Yet their impact on bones is especially fast-acting. Even low doses like 3 to 10 milligrams of prednisone per day can raise fracture risk, sometimes within months, and this risk can appear before a noticeable decline in bone density shows up. If you are prescribed steroids for more than a short course, asking your doctor about protective options, such as bone-strengthening medication or supplements, can help reduce long-term harm. Cancer therapies also demand attention. Aromatase inhibitors, used in the treatment of breast cancer, reduce estrogen to extremely low levels, leading to rapid bone loss. Similarly, androgen deprivation therapy, given to men with prostate cancer, cuts testosterone, which accelerates bone density decline by several percentage points within the first year. Both therapies are life-saving, but current guidelines recommend baseline bone scans and preventative measures, such as vitamin D support or bisphosphonates, when these treatments begin. If you or a loved one are starting one of these therapies, bone monitoring should be part of the care plan from day one. The risks also grow when medications stack together. Polypharmacy, a common reality for older adults, can create compounding effects. For example, someone taking an SSRI alongside a PPI may face far greater fracture risk than with either drug alone. This is why it is critical to not only review each medication in isolation, but also ask whether combinations may be increasing cumulative risk to bone health. The good news is that this is one area where small actions in the clinic can prevent major consequences later. Here are 3 specific questions you can bring to your next doctor's appointment. Do any of my medicines increase fracture risk? Can we review alternatives or adjust the dose or duration to lower that risk? And should I have a DXA scan or a FRAX-based fracture risk assessment now? These questions ensure that bone health is included in the medication discussion rather than left as an afterthought. Recognizing medication-related bone loss gives you the chance to act before a serious fracture reshapes your independence. Instead of being caught off guard, you can approach treatment with a fuller view of both benefits and side effects. But medication is not the only area where assumptions can mislead. Many people continue to believe that bones are strong as long as calcium intake is high. Yet the reality is more complex, and understanding that puzzle is the key to protecting your skeleton over the long term. For many people, the conversation about bone health has been reduced to a single nutrient: calcium. The advice sounds straightforward. Drink your milk, take a pill, and you're covered. But research shows that this is far too simple. Bones depend on a wider network of nutrients, and focusing only on calcium may ignore, sometimes even worsen, the real risks at play. This is why experts increasingly talk about the nutrient puzzle of bone health, one where calcium is just one piece of a much larger picture. The so-called calcium paradox highlights this complexity. Populations with high calcium intakes, such as those in Western countries, often have higher fracture rates than places with much lower calcium intakes. What this tells us is that more calcium in the diet does not automatically translate into stronger bones. At the same time, research has raised possible concerns about high-dose calcium supplements. Unlike calcium from food sources, which is absorbed gradually, supplemental calcium in large amounts can enter the bloodstream suddenly, and some studies link this to a higher risk of calcium settling where it doesn't belong, in arteries, contributing to stiffness and calcification. This is not a reason to avoid calcium altogether, but rather a reminder to distinguish between dietary calcium, which is generally beneficial, and supplemental calcium, which should be reviewed with a clinician. Calcium also cannot work in isolation. Vitamin D plays an essential role by signaling the gut to absorb calcium from food. Without enough vitamin D, much of that calcium is wasted. Deficiency is common in older adults, especially in regions with low sunlight, making testing vitamin D status with a simple blood measurement, 25-hydroxyvitamin D, a very practical step. If low, steady daily supplementation is standard and often necessary. It's worth noting that very large bolus doses of vitamin D, given all at once, have been linked to more falls and sometimes more fractures. For most people, smaller, regular doses are safer and more effective. Even when calcium and vitamin D are sufficient, the body still needs guidance so calcium ends up in bone, not in soft tissue. Vitamin K2 is part of that system. It activates proteins such as osteocalcin, which direct calcium into the skeleton. Studies looking at vitamin D combined with K2 suggest modest improvements in markers like bone mineral density compared to vitamin D alone, especially in postmenopausal women. While still an emerging area of research, this combination appears promising. However, experts recommend that people discuss K2 with their doctors rather than self-prescribing large doses. This is especially important for anyone taking blood-thinning medications like warfarin, since K2 can interfere with their effect. Other nutrients also matter. Magnesium, often overlooked, is a cofactor in the enzymes that form new bone. Many older adults consume less than recommended because foods like nuts, leafy greens, and whole grains are missing from their diet. Protein is another critical factor. Bones are about 50% protein by volume, mainly in the form of collagen, which serves as the scaffold for minerals. Without enough dietary protein, bones lose this matrix, becoming brittle, while muscles that protect against falls also weaken. A practical takeaway here is simple. Try to include magnesium-rich foods daily and maintain a steady protein intake appropriate for your age and activity level. If you struggle to meet those needs, discuss supplements or protein support with your clinician rather than guessing. Pulling all of this together, it helps to think of bone strength as a checklist rather than a single answer. First, check vitamin D status through a blood test. Second, ask your doctor whether vitamin K makes sense in your situation, especially if you take warfarin or similar drugs. Third, focus on food sources of magnesium and protein before relying on supplements. Last, review whether calcium supplements are actually necessary, aiming to prioritize dietary calcium whenever possible. When each of these steps is considered together, bone support becomes balanced and safer than relying on one nutrient alone. Understanding this puzzle not only changes how we think about nutrition, it reshapes how we think about bone care as a whole. Fragility later in life is rarely caused by a single missing nutrient, just as it's not caused by age alone. It's the combined effect of medications, inflammation, activity levels, and nutrient imbalances that determine risk. And once you see the issue in that wider frame, it becomes clear that protecting bone health depends on addressing those often overlooked factors directly. That larger perspective is the real key to avoiding the fractures that many believe are simply a matter of getting older. Bone fractures in later life don't appear out of nowhere. They're often driven by hidden influences like medication side effects, chronic inflammation, and nutrient gaps. Recognizing these factors means you can act before a fracture ever happens. Research shows that older adults benefit from bone-sparing treatments and lifestyle changes, with improvements sometimes seen within just 1 to 2 years. Fractures after 65 are rarely just bad luck. Many are preventable when you identify hidden causes and targeted action. At your next medical visit, ask 3 key questions. Should I have a DXA scan or a FRAX assessment now? Which of my medications raise fracture risk, and can any be adjusted or monitored? What is my vitamin D level, and should I add daily, not high-dose supplementation, plus consider vitamin K or magnesium intake? In the comments, share one medication you plan to review, and subscribe for more clear, prevention-focused steps that keep you in control of your health.